Good evening, everyone. My name is Dr. Mary Mwangi, a consultant anesthesiologist working at the KU Teaching, Referral and Research Hospital here in Kenya. I'm your moderator for today. So feel most welcome from wherever you're joining us for this weekly webinar session. Today's topic we shall be discussing prioritizing patient safety, a case study of SMILE train safety and quality standard implementation. Maybe a few things before we get on to the program. I'd like to brief you a bit. So feel free to ask questions. You can always load them up on the chat box. We shall have the question and answer session at the end of the presentations. I also want to thank our sponsors for today, KSA for hosting this meeting, and also SMILE Train. Our first presenter, and actually the main presenter of the day, will be Dr. Fred Bulamba. He's a pediatric anesthesiologist at KUTRRH Children's Hospital in Uganda. He is also the WFSA representative in East Africa. He has worked with SMILE Train for 3 years as a reviewer and auditor. So Dr. Fred Bulamba, most welcome. You can go ahead and start the presentation.
All right, thank you, Mary. Could you please say SMILE Train if you can hear me?
Yes, I can hear you, Fred.
All right, thank you. Colleagues, friends, and everyone on today's webinar, thank you very much for joining in. Mary, thank you for that very quick and short introduction. There is nothing more to read, really. Yeah, today I'll be talking about prioritizing patient safety, and this is what is happening at SMILE Train, which I've been working for in a honorary capacity for about 3 years now. So let me just start by very quickly acknowledging the wonderful team of amazing people that I work with, or that I've worked with at SMILE Train in the last 3 years, including the guys running the show, Jen, Joseph, Esther, Prior, and then editor, some of the auditors and reviewers, including Zipporah, and Dati, who happen to be speakers this evening as well. I would say that there is some disclosure to make, because this is the position that I hold. Sometimes I get some honorarium, so sometimes it's the work I do is paid for, and that's important as we start. So very quickly into SMILE Train. So SMILE Train is a cleft lip and cleft surgery, cleft lip and cleft palate surgery non-government organization that we've seen grow so rapidly and so fast since 1999 to cover the countries that you see in color on that map. It means that if you are running such a huge organization, there are definitely some things that you're going to have to do right. You're going to need to set systems that can ensure that surgery for these patients is delivered in a sustainable but also safe way. And so that will introduce us to the sustainable partnership model that SMILE Train runs. And I don't want to bore you with details. You can visit their website, or our website, at smiletrain.org. But basically what has happened over the years is that SMILE Train has moved on from the traditional model of providing medical care in low middle income countries, where we talk of short medical missions, guys coming in and do camps and then go. So at the moment, Smile Train, I would say 95% of its work is through partners that local in the countries where it works. There are only very few situations like in Somalia where it's quite hard to have a number of partners like that, where sometimes teams can be led in, but even this is changing. And what's doing therefore is to empower the local teams in these countries to be able to perform surgeries and support them with the things that they will need to do that. So we've seen over 90, we've seen Smile Train expand in over 90 countries, working with over 1,000 partners. And I have to say that I think just recently they made 1.5 million cleft surgeries. And that's huge, that's huge. But in addition to that, there's been educational opportunities for the different teams that Smile Train works with. And let me quickly just talk about the teams. We're not talking about just the surgeon, we're talking about anesthetists, we're talking about nutritionists, we're talking about speech therapists, in addition to all the other people that would be required to deliver surgery. And this is the kind of partnership that that Smile Train runs. So what we bring to the table is a meaningful bi-directional partnership, because we listen to our partners and we stick to the contracts, we support them. The other thing that is really key is that, because pretty much a lot of cleft surgery is not an emergency, we would love to deliver this in a very safe way and provide the best care they can be. And so this is what we strive for. And then of course, we do not just do surgeries, we think about all the other issues around cleft lip and cleft palate. So these are the pillars that hold together this model that I've just described at Smile Train. And for me, really what I'm here to speak about is the safety and quality, because this is our number one. This is what we are best known for. So how did this develop? Let me quickly spend a few minutes talking about our safety and quality systems. I hope that by the end of this, we can find ways of relating this to the hospital care systems that we work in, and see what we can borrow from this. So really for us to be able to maintain safety of the care that we provide, we don't just wait to come to your theater and say, okay, we're here to partner. We start all the way from training of surgeons, in-service training of anesthesia providers, nurses, nutritionists, etc. So we start there, because it's only when we train that we can ensure a certain standard. The other big component is the equipment support, and here I'm talking about all manner of equipment that you would think about that would be required for a cleft surgery, including anesthesia equipment. And we've seen that in some partner centers, we've actually provided support to set up a whole critical care unit or a whole HD unit. So support is another way of ensuring that what we're asking for can actually be delivered. And how we get to that point of knowing what to provide is through the safety and quality assurance process, or standards that we're going to see. So these are mainly I think I can describe them in 5 ways. We carry out safety and quality assessments for new hospitals that would love to join or work with Smile Train. We do preventative audits after a certain period of time. And most recently, we introduced the annual self-certification audits, which is really done by the partner themselves. And then of course we have Sentinel event analysis and audit system. And we find that these have enabled us to actually be able to maintain the quality of care that we provide to our patients. I'm going to go in a little bit of detail regarding some of those. So how did this start? Smart Train, started in 1999. We've been here for about 20 years. And then over time, we have continuously thought of how to improve the quality and safety of care that we give to our patients. And so we've created the Global Medical Advisory Board, which was later not broken down, but rather later we constituted regional medical advisory committees. For example, Africa, where Gathuya is actually part of the Africa Medical Advisory Committee, which then informs the Global Medical Advisory Board. Is one of such an example, but we have these in all the different regions of the world where we work. And this is a very crucial point, because it's the guys that work in Africa that understand African systems and settings better. And so it's these guys who relay that information and relay the advice to the Global Medical Advisory Board. And we found that to be quite useful. We do preventive and Sentinel event audits. I think they started at around 2017. And recently, we actually just updated our safety and quality protocol in 2018. This is an evidence-informed document, and so we have to keep updating it to match with the evidence that is coming out as regards quality and safety. And then, of course, 2019 is when we started our self-certification audits. So the core of all this process is really our global safety and quality checklist, which I've tried to summarize on this slide. You don't have to spend so much time reading this. You can simply follow the link that I've provided there, or rather, follow that website. But really, we look at all the different areas in the pathway to provision of surgery. So from patient medical records all the way to postoperative care. And we want to evaluate the human resource, the processes, the documentation along that entire spectrum. And that is what really constitutes our checklist. Now, because over time there's been more evidence, there's been more other organizations involved in establishing these, like the recent WFSA standards of anesthesia practice. We also continuously update and include those. Sometimes they come as memos, sometimes they come as full updates to this protocol. And I have to say that some of the people we work with are actually very much involved in, for example, the WFSA standards. And so we are lucky to have that. So really the journey of the partner starts at the time when they either choose to be partners with Smart Train, or one of our staff decides that this hospital might be a good partner, and then we reach out to them, and then they are required to go through a rigorous process. And one of the things that we do in that process is assessing the facility for its preparedness to actually have this partnership. So this is again where we have our first opportunity to exercise our checklist and our safety and quality standards before the partner even comes in. And then after they've been, we've done the assessment, there will be some recommendations. Sometimes they're many, sometimes they're not. And then you start the process of actually becoming a partner. You go through some trainings on especially how to use some of the tools that we use at Smart Train. But once that partnership has been established, then it's our role as well as the partner's role to build capacity and strengthen the care system that our children will be going through, or our patients will be going through. I've shown you a picture on my left, which is a picture of cylinders. You could guess what gases are in there, but I just have to say that all this is oxygen. So all these cylinders contain oxygen. And this was at one of our partner sites, which we were evaluating for the partnership. And one of the recommendations was, for example, to make sure that all the cylinders look the same and they can be identified to have oxygen. So it's those kind of things that we look out for and ensure that they're done before you even join the partnership. Now, once you join, then there is going to be continuous evaluation. We usually target to do it every 3 years, especially previously where we had to come to the facility. We would do this every 3 years, and we call these preventative audits. Essentially, what we want to look out for is, are you sticking to the quality and safety protocols that you signed up for? Are you still delivering surgery in a manner that is agreeable to Smile Train? But it doesn't mean that we'll punish you if we find any gaps. Actually, what happens is that if there are gaps, then we'll work with you to fill them up and support you so that we don't lose partners. So we it's very, very hard for us to lose partners. We would rather support them and take them back to the level that we want them to be at. And this also, doing this kind of audits also informs the way Smile Train decides to invest its resources. And I will talk slightly more about that in the slides. Now, the other area that we look at for safety is Sentinel events. And we know that much as we would not love for any of this to happen, we know that they do happen even in our elective patients. And so there is a process to that. So when you're signing up, you agree to us looking into the documents, into the data for those patients who get Sentinel events. You agree to reporting Sentinel events as soon as possible. You agree to us coming to your facility to do an external evaluation, but also we very much encourage internal reviews by the hospital teams before Smile Train actually comes in. And usually we want to make sure that this kind of process is finished in about 3 months. You've sent us the reports, you've sent us the local hospital facility analysis, we've done the external analysis, we've done the facility audit, and then we'll give you recommendations. Sometimes we might have to temporarily stop the partnership until you put some recommendations in place. Sometimes we ask for timelines on when you're going to deliver these. And in all this process, we're also trying to make sure that the administration works together with the teams that are actually delivering care. So we interface not just with the surgeons, but also the administration. And that is quite helpful. So that's what we do when we get Sentinel events, which are not that many, but still happen. Now, the most exciting thing that has happened, before COVID, which was 2019, is the creation of this system where partners and hospitals can carry on the self-certification audit. Essentially, what I'm talking about is our partners can now go online and use the safety and quality checklist and go through each step of that checklist to try and identify where they have gaps and where they need more support. Now that this is available, this is online, that we request the hospitals to do them. once every year. So we've moved away from the 3 years physical audits. Perhaps we'll be doing those for some centers, but now we very much encourage the annual self-certification process. And we have some data on this. We had a pilot in 2019 where about 380 hospitals in Africa undertook this self-certification audits. What really surprised us, because this was the first time we were running it, was the high response rate. About 80% of the hospitals actually completed this process. Now, remember that this was the time before the world decided to go digital on everything. And so this informed us that, you know, we can do this. Actually, we can do this. It's feasible to do. It will be more sustainable. It will enable us to monitor what's happening at the hospitals and support them at an annual basis or every year. And so this proved a lot of things, and we've gone ahead with this process. Now, we also appreciate that, you know, there's some limitations with this kind of setting. There is going to be report bias, especially in the early stages before the hospitals really realize that this is of much value to them. But we also need to validate this, so we'll continue doing the physical site visits and audits, and hopefully in the long run, we can enable the hospitals to build stronger quality improvement teams so that when they do this, they actually do it very well. If there are people who are already partners listening in, I would say that this is a great opportunity for us to actually identify gaps and strengths in our partnership. And so I would encourage you to do this very well. So with all these processes for our safety and quality, you know, we can't do this without some investment, without some incentives. And these are some of the things that I want us to think about as we think about the care that we provide in our teaching hospitals, in our public hospitals. So the next few slides are going to be on the impact, and we're already seeing that you know, hospitals are learning to develop their own QI departments and QI systems from this partnership. They are also leveraging this partnership to ask for more investment from their administrators, or, you know, hospital owners, or the organizations that run the hospitals. And this is important because previously we would think that in a partnership like this one, everything would come from Smile Train, but we've realized that there is actually a lot of potential within the hospitals. It's just the connection between, you know, the external force that connects the care providers, the frontline care providers, and the administration. Mary, by the way, feel free to remind me when I have about 5 minutes left. Yeah. The other benefit or impact that we've had is that quite a number of our partners have members or team members that are now trained in the different you know, training opportunities that we have. We have basic life support and power is provided by AHA. Smile Train is actually now an AHA certified training site or training organization. We've supported safe PEDS, safe nursing care saves lives. That's another course for nurses. We've supported nutrition, speech therapy conferences, safe PEDS for cleft, which is a course that we're working on, and it will be coming through quite soon. But also we have enabled support in infrastructure development and equipment acquisition. So that is in a nutshell the impact that we're having, besides, you know, the provision of the surgery itself, besides those millions of patients that we've operated. Now, I have to say that this is not only informed by the safety and quality protocol audits that we run. It's actually informed by data. And there was a study that was published around 2018, which looked at really what the partners think they would need support in from Smile Train. And this was done all over the country. I'm going to show you another table which breaks it down. But basically, we know that almost 60% of our partners, and I'm talking at the individual level, want some financial support. They want some medical professional training, and a similar figure also wants equipment. Now, what was interesting with this is that this is really according to what region of the world you are in. Let me stick to Africa here. So in Africa, we saw that a lot of our partners actually would love for us to support equipment or equipment acquisition. That's the largest number. Of course, a lot of them want the medical professional education, they want the financial support, but really equipment was the sticking point here. Now, you would see that in other settings, different things like in North Asia, it's the medical training that they want most. In Southeast Asia, it's again medical training. In the US, it's equipment. So it's now what happens after we have this kind of data is that then we put out grants to actually support what the different regions want most. And over time, we've seen that partners in Africa have gotten more equipment grants, while those in Asia have gotten more of the education grants, like that. So we are really just responding to the needs of our partners. Very quickly, some of the capacity building equipment that we've provided to some of our partners are listed here, and this is just for the East African and maybe some Central African countries. So we're not talking about Africa here. This is just a snapshot of what we've been able to provide in the highlighted countries listed there. And this list is not exhaustive by all means, by any means. So yeah, but what we're seeing is that there is now an opportunity for us to give up more life box pulse oximeters to all our partners. Actually, we've provided surgical sets for the clefts, and now we have partnered with Lifebox to actually provide capnography, because in our reviews and audits, this was the use of capnography was really low, and so we're going to distribute these to our partners. Most of them have already received these. Some are just going to receive. We've also not walked away from our partners during the pandemic. And the organization just in this period has given out about $1 million for COVID-related items, PPE, hand washing facilities, pulse oximeters, thermometers, in addition to enabling continuity of surgery in those countries or in those partner hospitals where this is still possible. So this is the kind of partnership that we're running. This is the kind of response that we're having following our evaluations and audits. But I have to say that this would not be possible if the partnership was not set up in a way that there is actually someone knocking on your door asking you to do things the proper way. So if we are talking about scaling this to other facilities, you really need to have someone that you're accountable to, someone who will ask, why did this patient die, or why did this patient get amputated? If you don't have that kind of incentive, which might be a negative incentive, but if you don't have that kind of incentive, compliance to these protocols and guidelines that come out might be really hard. Now, of course, it also means that if you don't comply to the quality and safety standards that we expect at Smart Train, we cut the support, because you're contradicting the contract, the agreement that we signed up for, and so you need some external force that makes you accountable. And I think this is one of the things that we lack mostly in our hospitals, especially I can speak for Uganda, but I'm sure that this is similar across Africa. Of course, we cannot neglect the fact that we are not just improving care for SMILE trained patients alone. We are really improving care for all patients. The equipment that we provide, the training that we provide, all this eventually impacts other patients as they go through their surgery. So these are the kind of incentives that you need to maintain such a process. Yeah, I would be very keen to hear what you guys think, how else we can improve these kind of systems in our hospitals. Maybe we can have that in the discussion. Now, we know that this is not perfect and we're still continually working on it. I think yes, thank you, Joseph. So personally, what I would love to see is for hospitals to have well-developed QI systems and QI teams that can undertake these audits, and I don't have to travel to the facility to do that. But we're also finding that it's not, much as it may be easy to understand the level of equipment that the hospital has, the kind of processes that they have. It's really very, very hard for us to understand the practice of the providers themselves. And this is something that we are still trying to figure out how we can audit and assess. We all get out of anesthesia school as anesthesiologists or anesthesia providers, but what we really practice might not be the same. And so it's not enough for me to come to the facility and I say, okay, I want to see an anesthesiologist. The anesthesiologist will be there, but how they actually work and provide care might be totally different. So that's another area that we would need to improve on. And then of course, we've had a lot of partners asking for, where we have our guidelines are not in line with their national policies. And so we have to work to see that, we are quite responsive to that area as well. If, for example, your national policy requires that blood should be stored at another site when surgeries are happening, and yet ours is saying blood should be on the site, then there's a problem in there. But these are areas that we hope to work on. So as I come to the end of this presentation, we as SMILE Train, we are really keen on supporting our professionals and supporting the teams that we work with to deliver the highest level of quality of care, highest level quality care that we want for our patients. And we use our quality protocols, safety and quality protocols to do a number of things along that process. And we think that by prioritizing and incentivizing this process, we'll be able to, elevate the care that is being provided at the partner hospitals. Now, this is going to be my last slide, and I put it here because I know that a lot of us subscribe to the WFSA, and therefore we subscribe to International Anesthesia Practice Standards that came out, I think, last year. But the implementation is not happening as we would have loved to. And so the question is why? I want to challenge you that most of the problems really lie in the incentivization of the process, and this is what we need to think about. In your hospital, who are you accountable to? Who will ask whether you follow these standards? Who is answerable to who? What is the support and the leadership at the hospital like? If you say you want to get capnography, are you actually going to get it? So this is an area where we really have to reflect on how we do this. It's very good that there are organizations like SMILE Train, and recently I also listened to Dr. Kabetu's talk. There are organizations like this, but this has to be inherently embedded in the way that we provide care in all our hospitals. And so I want to end there and say thank you very much, and challenge you to push standards and quality and safety at all your workplace, whether you're working with Smile Train or not. And yeah, I would be very happy if you can link up with me. That's my Twitter and LinkedIn address. Link up, let's have a discussion. And yeah, thank you very much. Mary, over to you.
Thank you so much. Thank you so much.
Okay. Yes, thank you.
Thank you so much, Dr. Fred, for that wonderful presentation and a good overview of exactly what's happening in Smile Train, about what you're doing currently, even with the current COVID-19 pandemic, your plans, your future plans. I'm sure the participants have questions, so please post your questions in the chat box and we shall be taking them at the end of the session. So at this point, I want to invite the panelists, and I want to start by inviting Dr. Adamson Phiri from Senegal. Dr. Adamson, he's an anesthesiologist at the Barthimee Hospital. He's in Senegal. He's also the medical director, head of Department of Anesthesia, and he's a clinical instructor in the University of Thieves. He's also an American Heart Association BLS and PALS instructor. Dr. Adamson Phiri, most welcome. You can give us just briefly for 10 minutes an overview of safety and review program in Senegal.
Right, thank you, Mary, and thank you for everyone that's listening to us. We appreciate that you could make some time to listen to us, and thank you, Fred, for that wonderful exposition and presentation. As one of our leaders in quality and safety protocols in Smile Train. My experience, I would like just to share one slide, and I will talk about my experiences for a few minutes. So it won't even be 10 minutes, Mary, so don't worry. Can I share my screen? So I will just say a few things relating to the things that are on the screen. In my review experiences around the region, one of the things I've learned is that actually the review process is a very positive thing. It's true that we have changed terminologies a little bit, because before we used to use words and terminologies like audit, which carry a negative or a policing type of approach, but really it is not. It is coming alongside Smile Train in the desire to increase safety, especially around cleft care. One thing I appreciate about Smile Train is their focus is on cleft, and obviously the safety cannot be confined to only cleft. It will extend therefore to other areas of surgical care. So one thing I've learned is that usually incidents and accidents happen as a series of mistakes. It's not an isolated issue. It just doesn't happen. There are a number of things that are overlooked, or a lot of improvisation that that has not been tested or scientifically approved or studied, or and things like that. So it's a series of things that add up to accidents and incidents. And these are the things we need to avoid to increase the safety the safety margin, especially in this type of surgery, which is not emergency surgery at all. So I agree with Smile Trend that mortality needs to be zero in this type, because we have time to prepare and time to organize ourselves to increase safety to 100%. So if we have to improve, then we have to look to break down the accidents or the incidents, break them down at different levels of where they are most likely to happen. So that's why the protocols and the procedures that Smile Trend advances are important for partners and prospective partners to look into at all levels of surgical care, whether it's a nursing level or anesthesia provider level, surgical level, both before, during, and after the operations. An interesting concept that's growing now is the idea of kids operating rooms. It's something that we need to think about if we have to really improve on our safety margins. I applaud this initiative because most of our cleft surgeons patients are pediatric patients, and most of our ORs, even in pediatric hospitals, most of our ORs usually are not built with the pediatric patient in mind. The space, the machines, the equipment, programming, protocols. So usually you have to make a switch. You have to quickly switch from our routine work to adapt our provider experience to children. And that switching exposes us to a lot of possible series of mistakes. So if we can all go towards a world where if our patients are pediatrics, that we operate them in a pediatrics or that will go a long way. Another area is most of the world has moved on from halothane as an anesthetic gas to more safer gases, both intra-op and post-operatively, and even way after. And safer gases means an increase in safety in our cases. So we should probably aspire to go to change our machines, and especially in many places where I have been in my region, where we are still more halothane users, we can aspire to change to use more safer gases for surgery. And as Fred has said, N-tide or CO2s are becoming an important part of safety, both to verify correct airway management, but also when you have an accident or an incident, when you are resuscitating, EtCO2 becomes a very useful parameter to look at. Another area I would love to encourage us to look into is blood gases. When we are managing respiratory emergencies, in places where I have been in the region, blood gases are not easily accessible. I mean, you have to wait 24, 48, sometimes 72 hours before you can get a blood gas analysis if you have it. And in our reviews, in my reviews that I have done in the area, access to blood gases has been really something that's that's an area of lack. So is an iStat an option? I know that the prices are still way out of reach for that, but I will throw it out there as a suggestion, and it will help us improve management of incidents and accidents of the respiratory nature. And IO access is maybe common among pediatricians and pediatric providers, but in the general sense, IO access is still a procedure that many people don't run to when they need access, IV access. I have witnessed moments when we struggle so much to find an IV line in a shocked patient, and waste a lot of time when we could easily have IO access. So we need to popularize this, and this is taught in many of the training materials that Fred has mentioned. In PALS, and especially PALS and SafePeds, these skills are taught, but I think we need, in my region and in the regions that I've visited, demystify intraosseous access. I think with those remarks, I think those will be my throw in on what Fred has talked about in terms of safety. There are things that look way far out of reach, but look at us today. How many of us can work without without a pulse oximeter? 7, 8, 10 years ago, those were not common items in our areas of work. So why not push for safer gases, kids OR, ETCO2, iStats, and popularize certain emergency techniques like, among others, intraosseous access. Thank you, Mary. I will stop there for my intervention.
Thank you so much, Dr. Adamson, for sharing your experiences all the way from Senegal and emphasizing on safe anesthesia, especially for the pediatric age group. At this point, I want to welcome our second panelist, Dr. Amos Muzuka. Dr. Amos Muzuka is an anesthesiologist working at Mbeya Zonal Referral Hospital, which is a public hospital in the Southern Highlands zones of Tanzania. He is currently also working at the University of Dar es Salaam as a clinical lecturer in the Department of Anesthesia and Critical Care, where he also doubles up as the head of department. He also works as an independent reviewer conducting safety and Sentinel event audits for in Africa. He is a member of the Tanzania Society of Anesthesiologists, and let me say he has a perioperative patient safety at his heart. It lies right there at his heart. Dr. Amos, most welcome. You can give us an overview of the safety and review program in Tanzania.
Thank you so much, Dr. Mary, and thank you so much for having me. And I don't have slides to project, but just in a couple of minutes, I want to talk about the lesson learned from the Smile Train audit visit. And it's like that also I've been involving in visiting peripheral hospitals, being in a team from the Ministry of Health. We have that privilege to visit those small hospitals. So I just talk briefly on the lessons I have learned, when it comes to the concept of perioperative patient safety. So if there is a single sentence, perhaps I would say, or a big take-home message, I would say that having an enabling environment is really a fundamental to any change. So if you have a supportive environment, and here I mean, there are primary drivers of ensuring patient safety and quality, especially because we are anesthesiologists. I talk a little bit on perioperative patient safety. So we can't leave behind people from the government. So talking about governance, service delivery, human resource, and patient themselves, a population. And because time is short, let me talk a little bit on a very sensitive portion of patient safety, and especially perioperative patient safety. The experience and the lessons I've learned, hospital, they have their own internal review and audit team. And I think we all know the famous #1 mortality and the morbidity review meetings. Now, when I visited some of the hospitals and looked at the documents, it was obvious that these meetings, have turned into the meetings of shaming people, blaming people, and finding, a person, scapegoating individuals, and just to be ready to nail them on the cross. And that was a bad experience. So something I normally advise, and when I visit these hospitals, we have to change. I know we also in our hospital have this mortality and the morbidity review. We have to change. The process should normally focus on identification of the system. And let me repeat again, because when you identify the gaps in the system, then you'll have a little time to, blame people and finding people to nail them. So this meeting should normally focus on identifying the gaps of the system. It was very interesting. In one hospital again, I found they use a different method trying to, find the root cause of perioperative mortality and morbidity. They had a suggestion box in the operating theater where each individual is free to put suggestions. And I found this as a friendly method as they are trying to identify areas for improvement. But again, I think other systematic and a scientific method will be the one of identifying indicators of quality and then measure if these are really met. Now, for many years, we've been, I think, interested in, looking at mortalities, morbidity, those complications. But I think it's a high time that indicators now change and, look at things like waiting times, turnover times, material waste, and the rate of adverse outcome. So that's something I really learned. Well, during those meetings, people use a lot of, tools trying to find the root cause. How can we improve quality and the safety of patients? We can use, people have been using fishbone charts, famous 5 whys. But there are several tools, and some of these tools are used in non-medical professions. But I would say something I've learned, no matter what kind of a tool you are using to gather information, there are things which should be in common. Number one, I think this Smile Train has done a really great work trying to gather stakeholders, that all stakeholders need to be involved in the analysis. Because patient safety is not only an issue of anesthesia, it's a surgeon. As I said, it goes beyond that. So all stakeholders need to be involved in the analysis. But I find number two, during analysis, we have to have a detailed discussion. So there must be a detailed discussion and analysis. And let's avoid rushing to make a conclusion, because one of the meeting I attended, you see, you have a senior surgeon, you have a senior anesthesiologist. Quickly, when the case is presented, they jump and say, well, the possible cause of death or these complications were 1, 2, 3. So because they are senior, they do jump quickly to make a conclusion. So this is my personal opinion. We would avoid making a temptation to jump to the conclusion, because we have to allow people really to give suggestions. And each suggestion given, you must go down with whys, try to look really the root cause. But finally, as I said before, the goal in this facility internal review, call them review audits, to ensure quality and improvement, the goal should be to change the system and not to re-educate the users. I think this meeting, most of the cases, in most of the hospitals, are meeting of educating, giving lectures. But I guess the goal, and this is my personal opinion, should be to change the system. If you have a friendly environment like this, I suppose that slowly we shall be changing. So Mary, thank you so much. I thought, thank you, Fred and Adamson have talked a lot. I thought these were my opinions. Thank you so much.
Thank you, Dr. Amos, for being an advocate of safe anesthesia and change in Tanzania and sharing your experience and your vision. I am sure there are a few questions coming, so just don't leave yet. So right now, I want to invite Dr. Zipporah Gathuya. She's an internationally renowned pediatric anesthesiologist, mentor to many, and with over 15 years of experience in both the public and the private sector. She's currently serving as of the Global Medical Advisory Board of SmileTrain and as a secretary for Global Initiative for Children's Surgery. And it would be unfair if I don't mention that she was actually very instrumental in setting up and running of the Pediatric Anesthesia Fellowship at the University of Nairobi, which is the first of its kind in East and Central Africa. Dr. Gathuya, most welcome.
Thank you, Dr. Mary. You can hear me?
Yes, I can hear you, Doc.
Good. So I'm going to talk about safety, the topic that we have been discussing this evening. And what I would like to say is that anesthesia providers have been leaders in the improvement of safety in healthcare as a whole. And this may be because sometimes the accidents that may occur from anesthesia have very immediate and adverse outcomes. So it is prudent that we be leaders in this field of safety. One of the things about safety is that there has to be a standard that we are striving to achieve. And this standard may be what Fred has talked about, whether it is organizational generated like SmileTrain, or whether it is generated by World Federation of Societies of Anesthesiologists, or whether it is locally, like what we have for Kenya Society of Anesthesiologists, the national guidelines. All these things are standards that inform the maintenance of quality. So why is safety so important? It is that we have to maintain those standards. We have to prevent accidents. Like I have said, anesthetic accidents can be very immediate and have very adverse outcomes. But also it is a motivation for continuous improvement. When you have people looking at what their safety positions are, what they are doing, it is a motivation for them to keep doing better and better. And safety issues are cut across many fields, and you have issues to do with patient selection for which Smile Train is very keen about. One of the things that we really emphasize, patient factors, but also provider factors. Availability of the providers, attention to detail of the providers when they do their preoperative, in your intraoperative and postoperative management of patients. All these things feed to quality. What I would like to say to tie up what everybody has said is about documentation, because most of the time when we do reviews, either preventative or when there has been a Sentinel event, the main issue that comes up is documentation. Remember, we were taught that if it hasn't been written down, it hasn't been done. And I just wanted to spread a few points talking about documentation, because I think it is very, very key. It helps us see exactly what is happening to our patients, where we are coming from, where we are going, what we are hoping to achieve. If there is a problem or you have a Sentinel event, your documentation is the first thing that we go to see what was happening, what was done, were the processes followed to what we have recommended. Sometimes you find that people do the correct thing, but because they haven't written it down, there is no way of saying that they did the correct thing. Legibility of the documents so that people can read what you have written. Accuracy of the timing. When you give a medication, write the time that you have given it. When you record your vital signs on a real-time basis as much as possible. Because sometimes when we review documents, we see documents that probably suggest that the monitoring factors were entered retrospectively. So when you think about all those things, then you see how important documentation is to patient safety. When you label your drugs, that is also part of documentation, because you're writing what you're giving and avoid errors of this. So, and the other important thing I wanted to talk about in terms of safety is training. We have to keep training, we have to keep learning new skills, we have to keep updating what we know, we have to keep improving our competences. And this Smile Train is doing very well by providing training for the providers in the things that Fred talked about. And if you feel as a partner or as a provider that there is an area of need in terms of training, you can always reach out to us. Then we can look and see how that can be addressed. And I think, Mary, I will stop there and then we can proceed. Thank you.
Thank you, Gathuya, for emphasizing on safe anesthesia, emphasizing on documentation, continuous training, refreshing our skills, and actually getting updates now and then. And I guess that is actually the vision of us having these webinars now and then. So from there, I want to invite the director for East Africa for Smile Train, Jen Gige. Jen Gige joined Smile Train in 2008 and currently holds the position of the director. And her role, she's been in charge of supporting more than 80+ partnerships in 10 countries in the provision of safe and quality cleft care surgery. Since she joined Smile Train, she has successfully led the running of multiple cleft care and education training programs, and that has had a very tremendous impact in both treatment accessibility, safety, and quality of care provided in the East African region. Jen, feel most welcome. You can go ahead and share your slides.
All right, great. Thank you, Dr. Mary. And I know we have all been hearing about patient safety and the role of SmileTrain in this area, but I just want us to go right from the beginning and learn, for the ones who are not familiar with SmileTrain, to just know, to learn more about SmileTrain and the work that we do, both globally and locally. My name is Jane Gige. I'm Program Director for East Africa at SmileTrain, and I'm thrilled to have this platform to just speak a little more about what we do. I'll start with a brief background, and I just want to highlight that 200,000 children are born with clefts every year. And unfortunately, a majority of these do not get access to treatment. And as most of us already know, cleft is more than a cosmetic issue. It's not just about the aesthetics that you see. A lot of the patients, especially the ones that have cleft palate, have problems eating, they have problems speaking, breathing, they're prone to respiratory infections, middle ear infections, dental issues, and poor nutrition. It's actually estimated that 1 in 10 children born with a cleft palate dies before their first birthday because they're not able to, because they're very prone to malnutrition, and it's due to them not being able to feed properly. And it doesn't end there. There's also the psychological challenges that they have, isolation, stigma, and this really causes a lot of missed opportunities when it comes to education and income. And that's where it all comes together with SmileTrain. So we are an international children's charity, and we advance a sustainable approach to a single solvable problem, which is cleft lip and palate. And our goal is to give every cleft child the opportunity for a healthy and productive life. So our model provides support in terms of training and funding to empower local medical professionals to provide 100% free cleft care within their own communities. And through this model, we have been able to run programs in over 90 countries and work with approximately 2,100 medical teams to provide primary care in terms of surgery and also comprehensive cleft care in terms of nutrition, speech therapy, orthodontics, and psychological support for these patients. And these partnerships that we've had with our partners have helped us since 1999 be able to reach 1.5 million cleft surgeries globally. About 126,000 of these are in Africa and 10,000 being from Kenya, which is about 8% of the total number of surgeries that have been able to be done in Africa. So, and through these numbers, it's estimated that every 5 minutes, a patient receives a SmileTrain supported cleft surgery. So in the span of the 10 minutes that I'm going to be speaking, we'll have 2 surgeries have already happened somewhere in the world. At the core of our program is the belief that patient safety is of paramount importance. And to this end, we've developed the safety and quality protocol that Dr. Fred spoke about. And it outlines the basic elements to ensure safe and quality surgery. We also conduct the safety reviews that were also spoken about in length. And we also have made available an online cleft library that is free and accessible to anyone. So, and it has the latest advances to cleft care and research. I just want to talk a little bit more and highlight 3 developments that have happened in the more recent past in terms of safety and quality. So in 2008, SmileTrain was accredited as an American Heart Association training center, and which means that we are able to provide training and offer certification in basic life support and pediatric life support. And what that has meant is that all our partner hospitals are able to to have this training for their anesthesia providers, and some of them, their nurses, especially the ones involved in critical care. And if you have attended any of these trainings, you know how pricey it can be in terms of getting the certification. And it's really great that we are able to offer this free of charge to all our participants from our partner hospitals. The other thing is 2009, we formed the Africa Medical Advisory Council. Dr. Fred has talked about this. It's more of an extension of the Global Medical Advisory Board. And the members involve surgeons, anesthesiologists, speech therapists, orthodontists, and they provide us with local expertise for local Smile Train medical programs. And in the short time that the members have been active, they've provided us great feedback and recommendation. And some of the input has been them leading in education and training programs for our partners, them leading in the safety reviews that we just spoke about, and steering us through the COVID-19 pandemic, advising us on when to suspend programs, when to restart programs, and how to restart programs. You know, what are the minimum requirements for each partner that are supposed to be in place before resumption of care. In terms of safety and quality, they have, the members have also been very instrumental in helping us to standardize our care protocols and also provide advice on especially drug substitutes for mandatory medication that is not locally available. And more recently, in 2020, we partnered with Kids OR, an organization that I think most of us are familiar with. And this partnership is really grand, is unprecedented. It's very exciting for us because it will help us in providing pediatric friendly operating room to some of our partners in Africa. I believe we are projected to have probably at least 30 of this. In Kenya, the partners that have been selected for this are Meru Teaching and Referral Hospital and Makueni County Referral Hospital. And we are hoping that, and we know that this will greatly improve the quality of care that have been provided to not just cleft patients, but all the pediatric surgical patients. And we see these partners as centers that are going to be leaders in cleft care, or as we like to call them, cleft leadership centers, that will be able to be training hubs. They will be hubs for research. They will be able to provide a full spectrum of comprehensive cleft care, and not just for Kenya, but for the whole region. So I will stop there for now. But before I do, I just want to do some bit of a call to action, which will be threefold. Number one, I'll pose it more like a question and ask for the participants that are attending, is your team currently running an unsupported cleft program? And if so, please reach out to us. Together we can do more, and especially for the patients who are unable to receive treatment. And number two is, if you're interested in our safety review process and would like to join our team, please reach out to us. We are interested in adding a couple of more reviewers to help us with the physical audits, especially in Kenya and also in the region. Remember, it's more or less like a volunteer position, and we're seeking more of pediatric anesthesiologists, preferably the ones with critical care experience. And my third point is to the association, to Kenya Society of Anaesthesiologists. I know we've engaged in the past a lot, and we've been to some of the meetings, but I'd want us to explore more and how we can work together, especially on the training programs to improve care. For example, we have a couple of recommendations from our safety reviewers of some, especially simulation training for some of our partner centers. And we can also talk about, what else is needed in the country and how can Smile Train come into support. So I'll stop there for now. Thank you so much, and looking forward to the Q&A. If you need to reach out to us, please, our contacts are on the slide right now, and please feel free to talk to us. Thank you.
Thank you,
Over to
Jane.
you, Dr. Mary.
Thank you, Jane, for that overview of Smile Train. I'm sure we all know now what Smile Train is all about. Continue with the good work and the vision of providing safe surgery for our young ones, and most of all, for giving them a reason to smile. So at this point, we want to go to the Q&A session immediately. I can see for the Q&A session, we will pose the questions to our speaker and panelists. So I have a question here from Lule. He's asking, what is the demographic of your partner hospitals? Are they mostly privately owned or public hospitals? Yeah, maybe Dr. Fred, you can take this one.
Thank you, Mary. I think Jane might actually be in a better position for that one. Jane, what do you think?
Yeah, sure. Thanks, Dr. Fred. We actually have a mix of partner hospitals that we work with. They range from government facilities, that's the public institutions, to private facilities, to faith-based facilities. So we have a normal mix for the hospitals,
Thank you, Jane. Let me just add on, following up with a question, what has been your impression of the uptake of the safety and quality initiative? My experience as a reviewer and auditor is that it's really differs what level and what country the institutions are. There are countries where their public system works actually very well, and there are countries where the private, of course, works a lot better. But of course, it's generally easier to implement the protocol in the private hospitals, even easiest in the faith-based organizations. It's a bit of a challenge in the public institutions, but I think what helps us as Smile Train is that this is a standard. You either do it or the partnership will not continue. And so we have had even partners from the public hospitals respond quite well to our recommendations and our requirements. Thank you. I submit.
Thank you, Fred. Also, there's another question here. Do you keep data on patient outcomes at different sites, and not just data about immediate outcomes and long-term outcomes? And how has this informed you about the safety and quality initiative? Dr. Fred and maybe the rest of the panelists.
Yes, I think Dr. Zippy and Jane again would come in here. But certainly, yes, the data, I am under oath not to use patient, like granular patient data, and also not to use specific hospital information. So that's why you didn't see a lot of that in my presentation. But yes, we definitely use the patient data to inform some of the recommendations in the protocol. A very quick example is the realization at some point that working on children on clefts and palate at the same time was becoming a problem or was creating more complications. And so we revised that to say you cannot do them at the same sitting, something like that, especially if they're under a certain age. So we definitely use data, but I would love to hear what Zippy and Jen think about this.
Hi, yes, we do keep data on patient outcome. Actually, once we open a partnership with any organization or hospital, one of the things that we provide is access to a patient database where they would be filling in the records, the patient medical records, and that's what we used to pay for the surgeries that are being done or for the care that is being provided. And just to agree with Dr. Fred, yes, we use the data to influence the safety and quality protocol. Like when data showed a lot of the issues or complications happening, especially during the night for our patients, and especially for kids who really deteriorate very fast. That's where we had an addendum saying that patients who are less than 2 years, their surgery should only happen before 2 p.m. And also in terms of the complication that Dr. Fred was talking about the combo, and we only allow for combo surgeries to happen for patients who are more than 1 year. So for patients less than that, we don't allow for that. And most recently, because we are getting a lot more into comprehensive cleft care. So in terms of nutrition, some of the data showed that much as we previously had the standard being a patient should not receive cleft lip surgery if they're less than 3 months and if they're less than 5 kgs. But we really didn't have a measurement on our patient database to show the age appropriate weight. And it just ended up that the patients who are older than 3 months would probably have their surgeries when their weight was lower than what the standard was. And so we incorporated that into our medical record so that in case you're reviewing a patient, you're able to check whether they have age appropriate weight, and you're able to measure you're able to look at other anthropometric measures before surgery is actually done for that patient. So those are just a few of the examples, but we've always used it to improve the care that we provide and improve the safety and quality process.
Thank you, Jen. Dr. Gathuya, a comment?
Yes. I wanted to add that because now we have a database that is online that can generate a lot of the information that we need. Like they have said, we use that to improve our processes. And that is why, again, I was talking about documentation, because if we have good documents, it informs us absolutely what is happening. We can tell what are the commonest drugs that are being used, what are the commonest complications, what are not only about patient data outcomes, but also very many other things that we can pick from those patient documentation that can inform us, even as we train people, even as we put procedures and processes, like we have said, all those are informed by the data that we have collected on the patients that we operate on. And that has been very useful. And we hope that even going forward, we'll be able to use this data even more.
Thank you, Dr. Gathuya. Maybe the last question, and I would like to hear the views of Dr. Adamson and Dr. Amos. What are the major challenges that you have faced while you are trying to advocate for the uptake of this safe and quality smile training program in your countries? What are the major challenges?
Maybe I'll go first. Yeah, there's a lot of challenges, especially I think the biggest challenge is the challenge of resistance to change. When you are used to doing something in a certain way, adopting a safer way or a more, let me say, adhering to a new suggestion to do the same thing is a challenge specialized trained personnel who have been doing something for a long time. So resistance to change has been quite a challenge, in my opinion. But we are still faced with challenges, real challenges of infrastructure. Our buildings and our machinery still leave a lot to be desired in terms of performance and age, and we are not talking about state-of-the-art equipment, but just the basic equipment, like a functioning suction machine, good lighting, temperature monitoring in the OR, and things like that. So those equipment and infrastructure is still a challenge for everyone, I think, especially in my region here in the French region, where the countries that I visit a lot. There are people with very good intentions and with a lot of zeal to work, but are pulled down because of equipment and infrastructure. Another issue I would mention is scarcity of training in my area. I think that's maybe a general problem, but it's specifically much so, maybe not so much in Senegal, but in the neighboring countries where I usually visit. Refresher training, exposition to training that will improve practice is really hard to come by. So that those are if I might just limit myself to 3 challenges, I would mention those: resistance to change, equipment and infrastructure, and scarcity of training.
Thank you, Dr. Adamson. Dr. Amos?
Yeah, thank you so much. I think I want to differ from Adamson, and we are Africans, and we are all in Africa, so much of these challenges are the same. But yes, I wanted to cement on what Adamson have said. There is this concept of implementing science. I think it's really a big problem to the sites I've visited, at least. We read, and of course it's known that there is normally a gap between the initial publication of scientific evidence and uptake into the practice. What we call evidence to practice gap. So issues like surgical safety checklist, you would wonder, why is it that it's not implemented in many of the hospitals? Why are people reluctant, as Adam said? So it's really hard, and perhaps for us, perioperative, physicians and who are doing research, it's a place to research. Why is it simple things like surgical safety checklist, people are still reluctant to use it? Because we've known for many years that programs like enhanced recovery after surgery, when I implemented it very well, safety is really good, but there is still that a gap between believing the science and practicing what the science tells us. But the final thing I think, which is really a major issue, is issue of staff, a skilled human resource. You go to an area, first a few, and even if they are few, they are not trained. So you can imagine how things are. So we really need to have an equipped people with good knowledge and the skills. And thanks to Smile Training, because I think some of the areas I visited, hardly the theater team couldn't even do basic life support. Just cardiopulmonary resuscitation skills is a problem. Now, with the training brought by Smile Train, I think if other partners can join and we make it as a national agenda, every healthcare provider to have these basic skills, at least you can assure that, you know, our patient will be operated safely. Thank you so much.
Short of time, we can take this discussion further. I'm sure we've Dr. Fred shared the Twitter handle. So I was asking Doc for you to give us closing remarks so that I give the vote of thanks. Thank you.
Thank you everyone for attending this webinar. My final remarks would be that we need, as a people in the region, especially even West Africa, the whole of Africa, emphasize the importance of safety in the care that we provide for our patients, not only the ones that are smile trained, funded, but all the patients that we take care of. And as we improve the safety of the patients that we take care of, we look out for training opportunities so that we can increase and better our skills and competences, and also network with people that are in the same line that we are in the region, so that we can just keep making our practice and our care for patients better and better, because we only have ourselves to work with to make care better in our setup. Thank you very much, Dr. Mary.
Thank you, Dr. Gathuya, for those wonderful closing remarks. I want to end this webinar. Before I end this webinar, I want to thank our organizers, KSA and Smile Train, for sponsoring this webinar. And thank you also the participants for sparing the time to come and join us and listen to us as we convey the message of safety in anesthesia. Please join us next week. We will have another webinar, same time and same day. I am sure we shall be communicating via email. From me, have a good night. Your moderator, Dr. Mwangi. Thank you.